All right, good morning, everybody. We are going to endeavor to start on time. So welcome back to day two of the Southwest Valve Summit, year 4. I think some are new today, probably putting in a full day's work yesterday and coming for today and tomorrow. So today's your first day, welcome. The agenda today, and I'll just sort of give you the highlights of what we're planning to do. The first session is a series of talks and cases on mitral valve disease. After the break, we're going to focus on aortic and prosthetic valves. Then we've got a focus session right after lunch on TAVR and a series of really cutting-edge talks on TAVR. A lunch highlight for those that are interested is going to be barbecue, so stay hungry for the barbecue. After the TAVR session, we have a session on the right heart and the valves there and the challenges. And then we're going to finish with sort of a replication of our multidisciplinary valve conference, which is an event we do twice a month, where we just sort of do real-time decision-making around what we think are tough cases, and we discuss them, and your input will be very important when we get to that session. So my co-moderator for this morning is Dr. Kleiman here. He's director of our cath lab. Neil, why don't you have a seat up here at the moderator table? Moderate Dr. Kleiman. So I'll start off with, I'll say that I was finishing these slides last night, sitting beside my son, and he said, "Dad, who's Mr. Quantification?" and I think of Paul Grayburn when I think of Mr. Quantification. So what I'm talking about is, so this is really just a short case on MR quantification. We'll talk a little bit about some of the stuff we introduced yesterday, and then we'll follow it up in the session we have today. All right, so we'll get started. So this is the patient, 61-year-old female, referred for an outpatient TE prior to pulmonary vein ablation, so not an unusual scenario for us. She'd had paroxysmal atrial fibrillation for about 10 years and worsening symptoms for 6 months. Took a quick history, and sure, she had some frequent palpitations and fatigue, no real dyspnea. So really the predominant symptom is really AFib and fatigue. So this is her kind of one of the initial shots, transesophageal echo. LV function looks normal. You see these sort of big, billowy mitral leaflets. You see this, see if I can point to it here, kind of this paradoxical papillary muscle motion. And by that I mean in systole, the pap muscles, and Dr. Laurie is going to go through all of this in greater detail in the following talk. But just notice how these pap muscles go up in systole instead of down or laterally. So that's not the way they're supposed to go. We're going to hear more about that next. So there's a 3D shot. Doesn't add any real information, I'll be honest. But it shows the ventricle with some shading, and it's in gold. So that's all you get for that 3D. But 3D will become valuable. So this is an X-plane, of course, acquired through a 3D probe, really to show the extent that really there's no leaflet that isn't involved. If you're looking at your commissural view or your 3-chamber view, you've got the entire anterior leaflet, the entire A2 and P2 shown here. Everything's billowing. This would be described as a big Barlow's valve. As Dr. Grande Allen was showing us yesterday, this valve, if you were to take it out and cut it up and look at staining, it would have all kinds of glycosaminoglycans, and it would be relatively more hydrated than the typical valve. So if you think of functional MR getting these fibrotic, somewhat dried out, maybe even dehydrated valves, myxomatous valves are the other end of the spectrum. They get relatively wet, thick, floppy, and weakened. So that's what this valve is. So look at the 3D for a second. This may give us a little more information. It projects a little faded. It looks a little better on the monitor, but basically you see that all leaflets are involved. So I haven't really shown you any color yet. Any real predictions here? Is this going to be a lot of MR, no MR? Does a myxomatous valve guarantee significant MR? We'll do a quick show of hands. We've got a nice friendly group. So no MR? Okay, mild, moderate, moderate. Good. Any? Do a Doppler? From the interventionalist. I love it. He's fully converted. All right. Anybody think this is going to be severe?
Well, it depends on the annular dimension.
Oh, all right. Takes it to, yes, the annular dimension. Okay, and probably the annular shape. Is it flattened? Does it maintain the saddle? All of those functional issues, exactly. Very important. So It's hard to predict what the MR severity is going to be just looking at that, but there's probably going to be some. So let's do a freeze frame in systole. So QRS is down here. We're well into systole. Aortic valve is open. And yes, it's true on 3D. I could dial up the gains or not, but this is sort of nominal gain where we have a lot of gain, and then on 3D is sort of just turn down the gain until the blood mud or the stuff that's clearly blood pool goes away. So this is sort of the lowest, it's difficult to balance gain on 3D, but this is what we think is the best gain setting. And there's a visible defect right here. Okay, so let's look at that a little more carefully. So it's relatively late systole, but a sizable hole. Okay, so here's some color. So no tricks here. Again, let's pull. So we know it's not no MR. Who thinks this is mild? No takers. Moderate? Some. Moderate to severe? Severe. Okay, so we have that's kind of reflecting real world. We have a little bit of everybody thinking all of those options are possible. That's probably a weather alert or something. That could be somebody who's really concerned about this MR. So let's look just a little slower. That's right, it's the MR alert. It comes right to our phones. Okay, so let's look a little slower here. So if you look at what's occurring here, it really is a late systolic event. So watch how much that leaflet prolapses back until there's color. And we'll slow that down a little more. No, actually, we'll do that in a second. All right, so this is the CW through that jet. So the alignment is pretty good. It was a central jet. There's no reason to think that we're undersampling or the Doppler angle is a big factor here. So for at least half of systole, there's really no discernible MR, and all of the MRs occurring at late systole. All right, so how do we factor that in? And there it is, early, mid, and late. So no question, late systole, if I only showed you that still frame, and if that's all you saw, that would be considered by most severe MR. If I only showed you the early frame, you'd say it was mild. So most of this case is emphasizing that the timing of the event is very important in the quantification. So the coaptation defect takes time to develop. So let's look at some 3D quantification. This is a 3D color Doppler. So it was acquired at the biggest jet, so this is a late systolic acquisition, as most of this tends to be it's a peak instantaneous measurement. But how you do it is you simply freeze frame the color, and then you crop it. You define the long axis of the jet in two orthogonal planes. So this is one plane. It's very broad in this plane, the jet. As we heard yesterday, really the focus should be not on the length of the jet, but the proximal width of the jet and sometimes the flow convergence. But the proximal width of this jet is very wide in this view. This is the orthogonal view, rotated 90 degrees. It's pretty narrow right here. But all of this gives you the ability to cut right through the vena contracta, which effectively is where is the place where all the flow is going through, and you can actually do a vena contracta trace, and that's 1.1 centimeters. So by current guidelines, as we heard yesterday, a severe MR is defined as an effective regurgitant orifice area greater than 0.4. This is 1.1. So does this automatically indicate that this is severe MR? So again, the case here is to show that at one point in the cardiac cycle, there's a very big hole, but it's only at the very end of systole. So is this severe MR? So how do we quantify this? Any recommendations or suggestions? What's the next step? Okay. Okay, so you're looking for the physiologic effect of the MR in terms of PA pressure going up and symptom onset. Remember, this patient didn't have dyspnea at all, really, but it was palpitations and fatigue and paroxysmal AFib. Right. So go back, when does it generate the gradient? It's a 5-meter gradient, but it's only for a very brief period. So I think that's the key. That's a good point, that it's not a maintained 5-meter gradient for the duration of systole. So I think one of the things you do, one of the challenges here is it's a big hole at the very end of systole. What's the net flow effect? So we have a tool that helps us figure that out, and you heard about it yesterday, and we use it a lot, and this is exactly the sort of scenario when we use it, is a cardiac MRI. Because cardiac MRI doesn't care when the event occurs. It just looks at the total volume change over the cardiac cycle to estimate the net effect. So that's what we would do here. So here's the question: do we send this patient for a repair based on this data alone? How do we establish volume? How would we get an average volume? So again, that's what an MRI will do. It'll do 5 consecutive beats, and provided the R interval is not dramatically different, we'll get a good average of the flow. So yeah, let's go to MRI. So this is the MRI on this patient. Again, we see relatively preserved LV systolic function in short axis. You can see the same things we've already seen, billowy leaflets. You see this papillary muscle traction moving up towards the annulus. Even better here, perhaps in the 2-chamber view. So these are very stressed leaflets. There's some color flow, but really what I want to get to is the quantitation. So the measurement here, the end diastolic volume is 205. The forward stroke volume was 80. So the LV systolic volume is 63. We do the math, and here's the difference. So 142 minus 80. The regurgitant volume is 62 mils. The regurgitant fraction is 44%. So we have the 62 is over the number in the current guidelines. 60 is the cut point, and Dr. Graber sort of took us through where those numbers came from. And the regurgitant fraction is 44%, which is below the current guideline of 50. So you got one metric that's above the cut point for severe, one that's below. This is not uncommon, and then you got to make a decision, what is this? So the LV size is reasonably sort of upper normal, 205. So this is sort of the conclusion. This is what we got to. Paroxysmal AFib with worsening symptoms. So there had been a progression of her AFib, mild LV enlargement, severe LA enlargement. The TE, moderate to severe. We sort of fudged because we weren't sure. We had that one huge hole for a very limited time. And the MRI gave us a quantitation. And basically the patient was referred for a surgical repair with a maze. And that's what happened. Patient had a good response. Maze went well. Valve was repaired and has done well for a couple of years since. So any questions on that case? Try to highlight sort of some of the challenges with the quantitation. All right, well that was really just, yeah.
So your first one, paroxysmal AFib versus
Mm-hmm.
you could argue that the MR is severe or moderate. It's alcohol compressive.
Mm-hmm.
So worsening symptoms, compressive MR, who cares if it's one or
I guess the challenge is trying to sort out, is it causative of the AFib? So we know there's a symptom-rhythm correlation with the AFib, and we get these a lot where, the patients have been referred for pulmonary vein ablation. They come for a routine TE just to rule out clot in the appendix. And then all of a sudden you see MR, and you're like, we may have a cause for the AFib. It's hard to send the person just for a pulmonary vein ablation when the presumptive causative factor is still there. So that's hard to do. I don't know how to tease apart when enough MR can be blamed to cause your AFib.
I'm not so much concerned about the AFib as worsening symptoms.
Right, but is the AFib causing the symptom, or is the MR causing the symptom? I mean, she doesn't have dyspnea. She's got fatigue and palpitations, which could be AFib alone.
Yeah, but so let's have a, go ahead.
Yeah. Yeah. So do you need to have severe MR to have a big left atrium? No, we see a lot of people who have quantitative moderate MR or less, but they have AFib. There's a bunch of things that dilate your LA. AFib, MS, MR, LV diastolic dysfunction, and the other big one we see a lot of is liver failure. Just the high flow state. So, this is kind of a real world challenge, is big LA alone doesn't equal severe MR. Makes you think about it. Big LV, you're much more concerned about making that correlation. Yeah. Totally asymptomatic. Yeah, no AFib. Yeah, that's a tougher one. Then you'd kind of go back to your standard approach to moderate to severe MR, which is wait, Gerald.
Another factor in that asymptomatic group is looking at LV and systolic dimension.
Yeah.
That's going up from 2.8 to 3.5. Certainly there's some degree.
Sure.
If it's around 3.5 before, you want to think about doing something.
Yeah, and that's right. On the CMR, that was an impressive feature. That was the LV dilatation for, I guess I didn't show you here, body weight and stuff, but when you index it to her LV was getting big without another reason.
And another thing, just to keep people are operating under their MR within 3 months of the onset of atrial fibrillation. Atrial fibrillation is almost always cured simply by the mitral valve repair. So timing is important. A lot of EP literature shows.
All right, well, you come up behind the podium and keep talking to us.